Good morning everyone. Topic for today's presentation is revision of the surface and the living anatomy part 2. Here we are dealing with the surface and living anatomy of the lower limb and the abdomen. Now competency number for the lecture AN 20.7, 20.8, 20.9 and AN 55.1 and 55.2. The objectives of the lecture: you have to palpate and feel the bony prominences. You have to palpate and feel different muscles, perform movements to see the muscle action, feel the pulsations of the most of the important arteries, and locate the site of most of the superficial veins. Now first we will see the surface landmarks of the lower limb. In the thigh and the gluteal region, the anterior superior iliac spine, it is lying at the lateral end of the fold of the groin. Now this is the fold of the groin. At the lateral end of it, there lies the anterior superior iliac spine. Now the pubic symphysis, it is lying in the lower part of the medial plane and it is fed indistinctly. The pubic crest, this is a free rounded upper border of the body of the pubis and this is lying just lateral to the pubic symphysis. So this is pubic symphysis, just lateral to it. Here lies the pubic crest and at the lateral extremity of the pubic crest there is a rounded projection that is known as pubic tubercle. In case of males, this is obscured because of the spermatic cord. Now, the inguinal ligament, this is extending from the anterior superior iliac spine to the pubic tubercle and this is lying in the fold of the groin, which is present between the anterior abdominal wall and the front of the thigh. Now two very important entities, the mid-inguinal point and the midpoint of the inguinal ligament. Midpoint of inguinal ligament is the midpoint between the anterior superior iliac spine and the pubic tubercle, while the mid-inguinal point is the midpoint between the anterior superior iliac spine and pubic symphysis. Okay? So, the femoral artery is lying at the level of the mid-inguinal point. So, this can be asked in the viva. Now, the ischialtuberosity, this can be palpated around 5 centimeters above that of the gluteal fold, and this is also of the same distance from that of the median plane. Now here you can see that gluteofemoral fold 5 centimeters above, that is the ischialtuberosity. Then the iliac crest, this can be palpated throughout its whole length in the lower part of the back. Then what is that Latan's line? When you join the anterior superior iliac spine to the most prominent part of the ischialtuberosity, and this line, it crosses the apex of the greater trochanter and the center of the acetabulum. Now the importance of this line is it gives the assessment of the displacement of in case of fracture neck of the femur. So the trochanter is displaced behind and above this line. Now what is that adductor tubercle? A very important landmark. This is located onto the medial side of the thigh. When you place a flat of the hand on the medial side of thigh just above the medial condyle of the femur and then slipping the hand downwards. Now here you can see the middle finger will come in contact with that of the adductor tubercle. And when you give a deep pressure, the tendon of the adductor magnus can be recognizable immediately above the tubercle. On the posterior aspect, the buttocks is the rounded bulge on the posterior aspect seen. Now the gluteal region, this is formed by the hip and the buttocks, and on the side of the buttock there is a hollow. Can you appreciate this hollow? And just immediately in front of that there lies the greater trochanter of the femur. Now on the posterior aspect you can see here the fold of the nape. This is the intergluteal natal cleft, and the dimple seen on the posterior aspect on either side of this natal cleft. This corresponds to the posterior superior iliac spine, and this is located around 5 centimeters from the midline, and this corresponds to the S2 level. This level is very important as the spinal meninges they end here. Now moving on to the very important vessels, the femoral artery. The femoral artery, it is palpated at the mid-inguinal point. Very important thing, it is palpated at the level of the mid-inguinal point. Now what is that mid-inguinal point? Anterior superior iliac spine to the pubic symphysis, midpoint of that. Now where you will see that femoral nerve. Now this femoral nerve, this is lying around 1.2 centimeters lateral to the femoral artery. Now here you can see that femoral triangle and the relations lying in that triangle. Artery is at the level of the mid-inguinal point, 1.2 centimeter lateral to it is femoral nerve. And the femoral vein, it is lying just medial to that of the femoral artery. Now where lies this saphenous opening? This is the pubic tubercle, around 4 centimeters below and lateral to that of the pubic tubercle. Make a circle, and center of that is the saphenous opening. So this is around 4 centimeters lateral and below that of the pubic tubercle. And the great saphenous vein enters through that saphenous opening and drains into the femoral vein. Now for the sciatic nerve, we are going to make two lines. A line joining the posterior superior iliac spine and the ischialtuberosity. First point is 2.5 centimeters lateral to the midpoint of the line joining the anterior superior iliac spine to the ischialtuberosity. The second line is joining the ischialtuberosity to the greater trochanter and midpoint of that. So from here, the sciatic nerve, it enters into the gluteal region. Now for the demarcation of the superior gluteal artery, here you can see the superior gluteal artery and here you can see the inferior gluteal artery. Now for that superior gluteal artery, a line joining posterior superior iliac spine to the greater trochanter, and from that the junction of the upper and the middle third of the above line. So from this junction of it, you can make a curve like this. That will be the demarcation of that superior gluteal artery. Now for the inferior gluteal artery, a point is put 2.5 centimeter lateral to the line joining that of the posterior superior iliac spine and the ischialtuberosity, and this denotes the entry of the sciatic nerve into the gluteal region and just medial to it. So here you can see that sciatic nerve, and medial to that of the sciatic nerve there lies the inferior gluteal artery. The pictures are showing the movements of the hip joint. This is the medial rotation where you are rotating it inwards. Lateral rotation, then the flexion of the hip, extension of the hip, then this is the abduction going away from the midline and adduction going towards the midline. So these are the movements of the hip joint, and there is also circumduction is there. Now the surface landmarks of the leg. Here you can see the patella, then this is the tibial tuberosity, this will be the anterior border of the tibia. Then here lies your lateral femoral condyle, medial femoral condyle. Then on the posterolateral aspect of the leg, but lying vertically below that of the lateral condyle of the femur. So here there lies the head of the fibula. Then the medial and the lateral femoral condyles, medial and the lateral femoral condyles. This is medial malleolus, this is lateral malleolus. Then on the posterior aspect, here you can see the popliteal fossa. When you flex the knee against resistance, there you will find that deep depression. Here again you can see the anterior and the posterior view at the level of the knee. Posterior view is showing the popliteal fossa. Then this is the anterior view where you can see the medial condyle of the femur, the lateral condyle of the femur. This is the patella. Then the lateral condyle of the tibia, medial condyle of tibia. This is tibial tuberosity, and this will be the patellar ligament. Then moving on to the movements of the knee joint. Here you can see the flexion and the extension of the knee. This is the flexion, this is the extension, and around that longitudinal axis, the lateral and the medial rotation of the knee occurs. So this you have to do on your own. Now, the common peroneal nerve, this can be rolled against that of the head of the fibula. Now, where it is lying, this is lying just on the posterolateral aspect of the leg, and it is lying vertically below that of the lateral condyle of the femur. Now, and onto the just below that of the head of the fibula, there lies the neck of the fibula. Now, this common peroneal nerve, it rounds around that neck of the fibula. Now, for the tibial nerve, here you can see that popliteal fossa. Now, this is the upper limit of that popliteal fossa, and this is the lower limit of that popliteal fossa. So, this is extending from the upper limit downwards to the midpoint between the medial malleolus and the tendocalcaneus. So, this is lying midway in between that of the medial malleolus and the tendocalcaneus. So, this is your tibial nerve extending downwards. Now here you can see that common peroneal nerve, it curves downwards and forwards from the neck of the fibula. Now from here, common peroneal nerve, it divides into superficial and the deep peroneal nerve, while this deep peroneal nerve, it descends downwards, and the second point, it is lying midway between that of the two malleoli. So, from the neck of the fibula downwards towards the point lying midway between the two malleoli, medial and the lateral malleoli. This will be your deep peroneal nerve. Now, for the superficial peroneal nerve, from the neck of the fibula, it is extending downwards, and this is going. Now, for this superficial peroneal nerve, at the neck of the fibula, you can see here the superficial peroneal nerve. This is peroneus longus. Peroneus longus is allowed to contract by everting and plantar flexing the foot. Now, as it gets prominent on its anterior border, now at the junction of the middle and the lower third of the leg, it divides into the cutaneous branches and it pierces that of the deep fascia. So this is the superficial peroneal nerve. Now here you can see that anterior tibial artery, which is shown by the 8 number. Now this is lying just 2.5 centimeter below the medial side of the head of the fibula and going up till that of the midway between the two malleoli, the medial and the lateral malleoli. Then the popliteal artery, a horizontal line is drawn at the level of the popliteal fossa downwards. That is shown here by the number 3. And the posterior tibial artery, this is the posterior tibial artery shown by the number 4. Now for this posterior tibial artery, a point is made at the middle of the leg at the level of the neck of the fibula, and another point is made at the level of the medial malleolus and that of the tendocalcaneus. So this will be your posterior tibial artery. Now the surface landmarks of the foot, the head of the talus, it is lying around 3 centimeters in front from that of the lower end of the tibia, and this can be seen and felt when the foot is passively inverted. Then the navicular tuberosity, this is very important landmark, and this is felt around 2.5 centimeters in front of that Sustaintaculum tali. Now here lies your Sustaintaculum tali. Now what is that? This is vertically felt around 2 centimeters below that of the medial malleolus. So this is medial malleolus, 2 centimeters below it lies your Sustaintaculum tali. Then in front of it, 2.5 centimeter in front of that, there lies your navicular tuberosity. And the head of the talus, this is lying around 3 centimeter in front of the lower end of the tibia. The peroneal tubercle, this is lying around 2 centimeters below the tip of the lateral malleolus. Then the tubercle on the base of the fifth metatarsal, this can be seen and felt halfway along the lateral border of the foot. But for that medial cuneiform, you have to follow the tendon of the tibialis anterior. Ask the patient to dorsiflex and invert the foot and follow the tendon of the tibialis anterior as it gets inserted onto that medial cuneiform bone. The Sustaintaculum tali lying 2 centimeters below than that of the medial malleolus. A very important one, the dorsalis pedius artery. First point is midway between the two malleoli, and the second point where you are going to feel the pulsations, the proximal end of the first intermetatarsal space. So this is the point for the palpation of the dorsalis pedis artery. Now moving on to the muscle testing. The iliacus and the psoas major, it is known as iliosus. This muscle, this is tested by flexing the thigh at the hip joint against resistance in supine position, and here you can see the knee is flexed. Patient in supine position, knee is flexed, and you are asking the patient to flex the thigh at the hip joint, and you are giving the resistance. Now the pyriformis, this is tested in sitting position. Ask the patient to do the abduction of the thigh against resistance, and if there is pain in the buttock, the pyriformis is. The testing of the obturator externus, obturator internus, gemelli and the quadratus femoris. These are tested by two methods. First one, ask the patient to do the external rotation of the extended hip. The hip is extended and ask the patient to do the external rotation. And the second test, the hip is flexed and you are asking the patient for the abduction of the flexed hip, and these are against resistance only. Now this pyriformis, obturator externus, obturator internus and the gemelli together, now these act as a abductors in the sitting position. So they help to move the leading leg when you are getting out of the car. So these are tested by abducting in case of a sitting position. Now here to check the sartorius, thighs flexed, abducted and externally rotated at the hip joint, and you are doing the flexion of the knee against resistance. So this is the testing of that sartorius muscle. Thighs flexed, abducted and externally rotated at the hip joint, and flexion of the knee against resistance is tested. Now to test the quadriceps femoris. Now this quadriceps femoris, it is a chief extensor of thigh at the knee joint. Now how you are going to test it? The patient is in supine position and the hip are flexed. Now ask the patient, the knee is also flexed. Now ask the patient to do the extension of the flexed knee against the resistance and test the quadriceps femoris. Now what is the Q angle? Now this Q angle drawn from that of the anterior superior iliac spine to that of the center of the patella, and the second line is from the center of the patella to the tibial tubercle. This angle formed by the two lines, this is known as a Q angle. Normally the Q angle is around 15 degrees. If that is increased, that will denote the dislocation of the patella mostly onto the lateral aspect. Now for the testing of the gluteus maximus, ask the patient to lie in the prone position and the extension of the thigh at the hip joint against resistance with knee flex demonstrate the action of this gluteus maximus. This muscle, gluteus maximus, helpful in case of running, climbing the stairs, and this is the chief anti-gravity muscle in sitting from standing and controlling the flexion of the hip joint. Now the adductors of the thigh, these are the pectineus, adductor magnus, gracilis, adductor brevis, adductor longus, etc. Now you are going to ask the patient to do the adduction against the resistance. Or you can ask also to squeeze the thighs together or crossing one leg over the other. Also demonstrate the action of these adductor muscles. Now the abductors of the thigh, these are gluteus medius, minimus and the tensor fasciae lata. Ask the patient to do the abduction of the thigh at hip joint against resistance, and this will demonstrate the action of these muscles. Now for the testing of the hamstrings, ask the patient to lie in the prone position. The flexion of the straight knee. Now here you can see the flexion of the straight knee against resistance. This will demonstrate the action of the hamstrings. Now for the tendo-Achilles, soleus and the gastrocnemius. Now these are tested by asking the patient to do the plantar flexion of the foot at ankle joint against the resistance. And here the knee is extended. Now there is one more test, Thompson test, where the patient is in the prone position on table with heels off the edge. Now here the examiner squeezes the muscle belly of the gastrocnemius and the soleus. Normally on squeezing there is slight plantar flexion, and if the plantar flexion is absent, the tendon might be ruptured. So this is mainly tested by asking the patient to do the plantar flexion against resistance at the ankle joint, and the knee is extended. Now the dorsiflexes of the foot, these are tested by asking the patient to do the dorsiflexion of the ankle or foot at ankle joint against resistance. So this will make the tendons more prominent. Dorsiflexes of the foot are tibialis anterior, extensor hallucis longus, extensor digitorum longus, and that of the peroneus tertius. Now for testing that of the extensor hallucis longus individually, ask the patient to dorsiflex the great toe. Now for the extensor digitorum longus, the lateral four toes can be tested for the dorsiflexion against resistance. For the testing of the peroneus longus and the brevis, ask the patient to do the eversion of the foot against resistance, and this will make the muscle prominent on the lateral side of the leg. Now for the testing of the flexor digitorum longus, now this longus tendon, these are testing the distal, these are for the distal interphalangeal joint. Now when you ask the patient to do the flexion of the distal interphalangeal joints of the second to fifth toes against resistance, so this will test that flexor digitorum longus. Now for the flexor hallucis longus, the distal interphalangeal joint of the hallux can be tested. Now for the flexor digitorum brevis, now this brevis, this will be tested by the flexion of the proximal interphalangeal joints of the second to fifth toes. So brevis is testing that of the proximal interphalangeal joint, while the longus is testing the distal interphalangeal joints. Now the tibialis posterior, this can be tested by doing the plantar flexion and the inversion of the foot at ankle joint against the resistance. So the plantar flexion and the inversion of foot at ankle against resistance, this will make the tibialis posterior tendon more prominent. Now another very important test which is asked in the Viva, Trendelenburg's test. Now here the subject stands on one leg with the opposite of the ground. Now what happens normally, there is no drop of pelvis on the unsupported side. This is the normal person where you can see this is off the ground, and the here you can see there is no drop of pelvis on the unsupported side. But if there is weakness of the gluteus medius minimus obturatus, pyriformis and or quadratus femoris of the limb which is on the ground, if these are weak on the of the limb which is on the ground, then the pelvis of the unsupported side, this will drop. Normally this is at an equal level, but if the supported side muscles, these are weak, the muscles are gluteus medius minimus obturator, the pyriformis and the quadratus femoris, that will lead to the drop down of the pelvis of the unsupported side. So this is known as a Trendelenburg's test. Now moving on to the surface landmarks of the abdomen and the pelvis. Here you can see the anti-superior iliac spine. It is lies at the lateral end of the fold of the groin. Then in the midline, a linear depression is present that is known as a linea alba. Then the linea semilunaris, it is a curved groove crossing the costal margin at or near the tip of the ninth costal cartilage, and it is terminating below at the pubic tubercle. And this corresponds to the outer border of the rectus abdominis muscle. Then there is another entity known as a McBurney's point. Now this is situated at the junction of outer 1/3 and the middle 2/3 of a line which joins the anterior superior iliac spine to the umbilicus, and it is the point of maximum tenderness on palpation in the acute appendicitis. The point to note here is that the surface marking of the cecal orifice of the appendix, it doesn't coincide with this point. Now at the lower end of the median line, the pubic symphysis can be felt indistinctly. Then the pubic crest, this is the free rounded border of the body of the pubis, and this can be felt just lateral to that of the pubic symphysis. Then there is at the lateral end of that pubic crest, there is a rounded projection that is known as a pubic tubercle. Then on the posterior aspect, posterior superior iliac spine lying beneath that of the dimple by the side of this natal cleft. Then the highest point of the iliac crest, it is lying opposite to that of the interval between the spines of the L3 and the L4. So this is also known as a supracrystal plane. Then the second sacral spine, it is lying at the middle of the line joining the two posterior superior iliac spine. So the posterior superior iliac spine, it is lying at the level of the S2. Now for the convenience of the description of the viscera, the abdomen is divided by vertical and the transverse planes. So the sagittal planes here, the median sagittal plane which extends from the suprasternal notch to the pubic symphysis. There are right and the left lateral planes also. They extend vertically up from the midpoint of the pubic symphysis and the anterior superior iliac spine onto the lower aspect, while above midpoint of the line joining the suprasternal notch and the acromioclavicular joint. So these are the right lateral and the left lateral planes. Then the transverse planes. Transpyloric plane, it is also known as the plane of the Addison. It is indicated by a line midway between the suprasternal notch and the pubic symphysis. It is approximately lying midway between that of the episternum and the umbilicus, and it crosses the tip of the ninth costal cartilage, and it is lying at the lower border of the L1. Now at this level, the pylorus of the stomach, then the inferior margin of the liver, neck of the gallbladder, these are lying. Another transverse plane, that is the transtubercular plane. This is lying at the level of the tubercle of the iliac crest, and it lies near the upper border of the L5. There is one more plane, subcostal plane. This lies at the upper border of the L3, and this is drawn below that of the 10th rib. So, by these planes, the abdomen, it is divided into 9 quadrants. In the middle part, from above downwards, the regions are epigastric region, the umbilical region, and the hypogastric region. While onto the right lateral, right hypochondriac region, right lumbar, and the right iliac fossa, and onto the left lateral, left hypochondriac, left lumbar, and the left iliac fossa. Now here you can see the umbilicus. Umbilicus, this is a scar tissue left where the umbilical cord was attached in the fetus. Now in adult, its level corresponds to a line between L3 and the L4 vertebrae posteriorly. It is lower in the infants and when the abdomen is pendulous, while it is higher in the late pregnancy. Now here you can see the anterior superior iliac spine and the pubic tubercle. Now the inguinal ligament extends from the anterior superior iliac spine to the pubic tubercle. Then mark a point 1.25 centimeters above the midpoint of the inguinal ligament. So this point will be the deep ring. Then put a point just above the pubic tubercle. Here lies the superficial inguinal ring. And by joining this deep and the superficial, this is the inguinal canal around 4 centimeters in length. Now moving on to the surface anatomy of the aorta, abdominal aorta. Now here you have to draw the median and the transpyloric plane. A point is placed in the median plane around 2.5 centimeters above that of the transpyloric plane, and the second point 1.2 centimeters below and same distance from the median plane, that is 1.2 centimeters below and 1.2 centimeters from the median plane, and join these 2 points by 2 vertical lines around 2 centimeters apart. This is the abdominal aorta. Now for that common iliac and the external iliac artery, put a point 1.2 centimeters below the umbilicus and around 1.2 centimeters from the median plane, which we had seen just now. This indicates the bifurcation of the aorta. Now mark the midpoint between the anterior superior iliac spine and the pubic tubercle and draw a broad line joining these points, which represents a slight convexity to the lateral side. Now, the upper 1/3 part, this represents the common iliac artery, while the lower 2/3 part, this one, this represents the external iliac artery. Now moving on to the surface marking of the stomach. The stomach is having the cardiac orifice, the fundus, greater curvature, lesser curvature and the pyloric orifice. Now draw a median line. Now this is the median plane around 2.5 centimeters to the left of the median plane onto the 7th costal cartilage. Then this is the point where the cardiac orifice is lying. Then the pylorus, draw the transpyloric plane. So this is the transpyloric plane. At this level lies the pyloric orifice. This is around 1.2 centimeters right to the median plane. So this is the level where the pyloric orifice is lying. Then the lesser curvature, join the cardiac orifice to the upper margin of the pylorus by means of a curved J-shaped line. Then, for the fundus of the stomach, put a point in the left fifth intercostal space. This is lying just below that of the nipple. So, and draw the fundus as from the left margin of this cardiac orifice with upward convexity. The greater curvature of the stomach, put a point between the tip of the 9th and the 10th left costal cartilage. Now this greater curvature, draw a curved line convex to the left of the fundus. So this is the fundus. From the fundus, draw a line downwards which is reaching up till the subcostal plane and then reaching to the lower margin of that pylorus orifice. So this is the outline of the stomach. Keep in mind that the cardiac orifice is lying around 2.5 cm from the left of that median plane, while the pyloric orifice, it is lying 1.2 cm to the right of the median plane. Now for the duodenum, it is having the 4 parts: the first part, second, third and the fourth part. First part is 2 inches, second part is 3 inches, third part is 4 inches, while the fourth part it is a 1 inch in outline. Now the pyloric orifice of the stomach, it is lying around 1.2 centimeters to the right of the median plane. Now from that point, mark a point 2.5 centimeters above and to the right of the pyloric orifice. So this will become the first part of the duodenum. Then second part, this is the right lateral plane. Put a point which is around 7 centimeters below that of the transpyloric plane and medial to that of the right lateral plane. And the second part, it is wide, around 2.5 centimeters wide and A. So this is around 7.5 centimeters. Then the third part, draw the subcostal plane. Subcostal plane is lying at the level of the 10th rib. Draw the third part transversely from the end of the second part at the level of the subcostal plane and ending just to the left of the median plane. So this is the median plane. So this will become the third part of it. And the fourth part, this is around 2.5 centimeters to the left of the median plane, and it is around 1 centimeters below the transpyloric plane, and this indicates the duodenojejunal flexure. So this becomes the fourth part of the duodenum. The ileocolic orifice, this is lying at the intersection of the right lateral and the transtubercular plane. So here lies the ileocolic orifice. Then the root of the mesentery. The first point is drawn around 1 centimeters below the transpyloric plane, and this is lying around 2.5 centimeters to the left of the median plane. So this is the first point, which is lying 2.5 centimeters to the left of the median plane and 1 centimeter below the transpyloric plane. And the second point is the intersection of that right lateral and the transtubercular plane. And by joining these 2 points, the attachment of the root of the mesentery can be demonstrated. Now for the surface marking of the spleen, the upper border of it corresponds to the upper border of the ninth rib. Then a point is placed. This becomes the upper pole, which is lying around 4 centimeters lateral to that of the T10 spine. Second point is at the level of the left 11th rib in the mid-axillary line. Now this indicates the lower pole of the spleen. And by joining these two ends by a curved line, this is extending upward and forward to the ninth rib, and the long axis of the spleen, it is lying along that of the 10th rib, and the width of the spleen, this is extends through the 9th and the 10th intercostal spaces. So this is the outline of the spleen, where the axis of it is lying along the 10th rib. Upper pole corresponds with that of the 9th rib, upper border of the 9th rib, and the lower pole is lying at the left 11th rib in the mid-axillary line. Now for the pancreas, the head of the pancreas, now the transpyloric, subcostal, the medial and the right lateral planes, these are present. Now from the transpyloric plane, median plane, 1.2 centimeters to the right of the median plane, this will become the first part of the duodenum. Then second point is 2.5 centimeters above and to the right of the first point. Third point, this is 7.5 centimeters below the transpyloric plane and medial to that of the right lateral plane. So by joining this will become the first part, second part. Then a fourth point in the subcostal plane, just to the left of the median plane. By joining this will become the third part of it, and a fifth point, 2.5 centimeters to the left of the median plane and 1 centimeter below that of the transpyloric plane. So this will become the fourth part of it. Now in the duodenal part, here lies the head of the pancreas. The neck of the pancreas, it passes upwards and to the left, and this is the junction between the head and the body of the pancreas. The body of the pancreas, this can be represented by two parallel lines, which is around 10 centimeters long and 3 centimeters apart, going to the left from the neck, and the tail of it extends to the left as far as the hilum of the spleen. So this will become the outline of the pancreas. Now for the liver, it's having the upper right and the lower border. Now for the upper border, mark the zipisternal joint. Then put another point little below that of the right nipple, and the third point little below and medial to that of the left nipple. So this will become the upper border of the liver. Then the right border, a point is put 1 centimeter just below the tip of the right 10th costal cartilage. So this is the right 10th costal cartilage. Draw a convex line from below to the right nipple. So this will become, this is convex line up till that of the right nipple. So this will become the right border of the liver. Then for the lower border, the median and the transpyloric planes are drawn, and mark the tip of the right 9th costal cartilage. Now join the lower end of the right border to the left end of the upper border by a line crossing the median plane at the transpyloric plane. Now this border, it should show a slight notch opposite the tip of the 9th costal cartilage for the fundus of the gallbladder. So a slight notch opposite the tip of the 9th right costal cartilage. This is for the fundus of the gallbladder. Now for the surface marking of the kidneys. Now draw the median and the transpyloric plane. Now the hilum of the kidney, this is around 5 centimeters away from the median plane. Right kidney, this is lying little below than that of the left kidney. Draw the outline of the kidney, which is around 8.5 centimeters in length and 5 centimeters in the breadth. The point to note here is the upper pole of the kidneys. These are lying around 2.5 centimeter from the median plane. Hilum is lying around 5 centimeters from the median plane, while the lower pole of the kidney, these are lying around 7.5 centimeters from the median plane. The right kidney is slightly lower than that of the left kidney. Then there is one important renal angle is there. This is lying between the lower border of the 12th rib and the lateral border of the erector spinae muscle. The importance of this is the renal colic pain. This starts from this angle and it extends downwards and forwards and towards the groin. So this is the importance of that renal angle. This can be asked in the viva. These are the references for the lecture. Then just to summarize, we had seen the surface landmarks of the lower limb and the important muscles, how to test the action of the muscles and the movements of the joints. And for the abdomen, we had seen the important surface landmarks and the surface markings of the important organs. Thank you.